Hi, I'm Mary Sue Rominger. I'm on the Board of Directors and a volunteer here at the Bateman Horn Center. Welcome and thank you so much for joining us tonight. We will be posting a video of tonight's presentation on our YouTube channel within the next few days, so don't worry if you miss something, you can go to the video and check it out again. We do plan to do a Q&A at the end of the session, so if you're on Facebook Live, you can use the comment section to ask your question. And go ahead and just ask that question at any time, and then we'll address it at the end of the presentation. Our speaker tonight is Dr. Matt Nelson, and Dr. Nelson received his Doctor of Physical Therapy from Regis University at Denver, Colorado, sorry about that, in 2006. While at Regis, he spent 3 years as an assistant instructor of anatomy and musculoskeletal management. After moving to Utah, Dr. Nelson successfully worked with the Professional Licensing Board and the Utah State Legislature to pass a law in 2014 that allows physical therapists to perform trigger point dry needling here in Utah. Because of his efforts, he was awarded the Utah Physical Therapist of the Year in 2014, and he also teaches this needling technique to other physical therapists across the United States and in Canada. In 2018, he obtained his therapeutic pain specialty from the International Spine and Pain Institute, recognizing him as an expert in the treatment and education for chronic and complex pain conditions. Currently, Matt is the owner and practices physical therapy at Dynamic Physical Therapy here in the Salt Lake area. And tonight, Dr. Nelson will be sharing his experience and insight on chronic and complex pain. And for you Star Wars fans out there, you're in for a treat tonight, and you'll see what I'm talking about shortly. Please welcome Dr. Matt Nelson.
Thank you. Thank you, Mary Sue, and thank you to the Bateman Horn Clinic for allowing me to be here tonight. I hope you guys are entertained. Hopefully you learned something. And hopefully it poses some new questions for you to start asking your healthcare providers moving forward. But let's get started. Okay. Like Mary Sue said, I'm a Star Wars fan, and hopefully you're entertained by this. So a brief time ago in a physical therapy, not so far away, we introduced Pain Wars. Okay. We're going to talk about a new treatment approach that physical therapists around the country are starting to implement into their practices to help treat patients with chronic pain or complex pain. So I'm affiliated with a couple different companies. So KinetiCore is the teaching company that I teach with for the dry needling. Dynamic Physical Therapy is a clinic that I own, and then the International Spine and Pain Institute is where I've got most of my training through. So how many of you are here today because you had thoughts or feelings similar to this? Okay. Many of you out there. Otherwise you probably wouldn't be here. Which often will lead you to a nice looking physical therapist. So our objectives tonight, basically to give you a history of pain and the current geography of pain here in the United States, understand the science of pain, how it works in the human body, through various analogies and stories that I've been exposed to and come up with. Explain how we as physical therapists go through an examination and treatment to treat chronic pain and complex conditions like chronic fatigue syndrome and fibromyalgia. Discuss the different roles healthcare providers can assist in managing this pain, and specifically how physical therapy is a major contributor to this. I'd like to identify various interventions that have been shown to be effective for chronic and complex pain conditions. And last but not least is just educate people with chronic and complex pain on how we can build an alliance together to help you guys feel better and make things a little more manageable. Okay, so I have little titles that go along with the Star Wars theme, but the pain menace. So disability and low back pain has increased through history, but why? Okay, so here's a few things that we've been able to identify. Because has our anatomy really changed in the last 200 years? not a lot. However, there's been technological advances that have exposed us to more pain. A few of these examples is in the 1800s, we saw a spike in low back pain because of the railroad and so many people working on the railroad and that heavy repetitive labor that came about. The invention of the X-ray and the MRI. Now we can see what's on the inside. And sometimes that's helpful, and as you'll see here soon, sometimes it can create the sensation of more pain or more problems. World War I and II saw many advances in medical care and surgical techniques, many of them very good, some not so good. And in 1930, the AMA started driving this bulging herniated disc philosophy out there to the public, and depending on who you talk to, created some scares, because a lot of times this is a normal phenomenon that occurs. Facts about pain, just in general for you guys. 126.1 million of Americans deal with persistent pain that lasts over 3 months. That's about 1 in 4 people. 30% of them who have chronic pain have never really had an initial injury that started their pain. 10% of the patients that receive health care take up 90% of the cost in treating pain specifically. And a patient with chronic pain averages about $31,000 in health care expenses. So, what is pain? And that's kind of a tricky one to define sometimes. So I'm going to give you a couple definitions from some authorities out there. The first one's the International Association for the Study of Pain, and their definition is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This next definition I really like is from Lorimer Moseley. He's out of Australia, and he defines pain as produced by the brain after a person's neural signature has been activated and concluded that the body is in danger and action needs to be taken. So a neural signature is basically a network of 9 specific areas of the brain that have been identified that light up when somebody's experiencing pain. And these specific areas, I can go in a little more detail, but these areas control things such as emotions, movement, concentration, problem solving, memory, fear, stress responses, balance, cognition, spatial recognition, and the amount of information that's coming in just from the spinal cord itself. So you can see a lot of different areas that can be affected. So people that experience chronic pain often complain of struggling with recalling memory or being able to focus or something. That's because the pain experience is taking some of that area of the brain and focusing it more on pain than what it's designed to do. So, okay, so a little more background on stuff. So the drug, imaging, and surgical wars out there. So these are just facts. So just to throw it out there. So basically 100 Americans die each day from opioid complications or overdoses. 80% of the world's opioids supply is consumed in the US, which makes up only 5% of the world's population. Morphine consumption in the US is 87 milligrams versus the world roughly is 6 milligrams. So some big discrepancies between the US and the rest of the world. And there's various reasons why if we want to get into that. But some other things just for chronic pain types situations specifically to do with the spine is the biggest predictor of somebody having spinal surgery is the zip code you live in. It says if there's more spine surgeons available, the likelihood of having spine surgery goes way up. So, because if there's a nail that needs to be hammered, there's people around that can hammer it. There's a direct correlation to the more images you have, the increased likelihood you may have a surgery, which makes sense. If it's broke, there's somebody there that potentially can fix it. This is somewhat alarming, but spinal fusions have increased 77% from 1996 to 2001 alone. I'm sure it's gone even up more since then, but that's the most accurate data I had available to me. The cost of a spinal fusion is $80,000. So, and of all lumbar spine surgeries out there currently, 60% of them are considered successful. And success in the literature is if your symptoms improve by 50%. So, a little more background on just fibromyalgia. So 6 to 10 million people in the U.S. have fibromyalgia. It's a $14 to $20 billion industry in healthcare alone. Women are 10 times more likely to be diagnosed with it, but why is that? So, one thing, women are more likely to seek healthcare than men, so it's just, by numbers. Women are more likely to fill out surveys than men to help identify if they have fibromyalgia. There is increased activity in the emotional areas of the brain in women, which releases different types of chemicals, which makes you slightly more, it makes you more expressive in the feelings you're experiencing compared to men. So it's easier for women to be diagnosed. So it used to be classified as a rheumatoid, inflammatory, or muscular condition. Now they're starting to think that it's more of an immune deficient dysfunction. And then did you know that on blood panels, people that have fibromyalgia have similar blood panels to those that have the flu? So a common complaint that I'll see in the clinic for people that I work with that have fibromyalgia is they feel like they report to me that it feels like I have the flu 24/7. And there is now some proof of that blood panels look pretty similar. So background on chronic fatigue. So there's 200 cases being identified each year. We don't have an exact cause of this, but CDC is now saying that fatigue plus 4 of these other symptoms for more than 6 months is how they're currently identifying it. Again, 85% of people are women. Again, it's probably for the same reasons, similar reasons as what I mentioned before with fibromyalgia. 94% of you report persistent pain, and anywhere from, according to the studies, 35% to 70% of people with CFS also fit the criteria for fibromyalgia. So there's some crossover. Okay. So now we're going to get kind of more into the pain education portion of things. So 40% of people currently have a bulging disc but have no pain at all. So within 2 months of an acute herniated disc, the bulge reduces by 50%. And then within 9 months, most bulging discs will reabsorb on their own. So some other just fun facts. If you have a rotator cuff injury, 1/3 of people over the age of 30 have an abnormality on an MRI finding, but have no pain. And by the time you reach 70, 66% will have an abnormality, but still no pain. So, and this is an interesting graph here. This is just looking at low back pain. So the orange bar is people that actually seek care, and you can see there's a big spike in your 30s to 50s with it peaking around 40. But yet, if you look at MRIs of people across their ages, we see more arthritis and dysfunction as you get older. So pain doesn't always correlate with the findings that you see on imaging. So this is kind of just normal aging that we go through, but it doesn't necessarily correlate with you having a pain experience. So what leads to all this, and what leads to a pain experience? And fear is a big thing that drives fear. And this is a really nice image here from Vlayan, in the fact that the fear of pain is often worse than pain itself. That was by Dr. Waddell. But say you have an injury here. Everybody's going to go through a pain experience with that injury. Now, if you're familiar to it, you may ignore it or say, you know what, I've had this before, you know, I twist my ankle a little bit, I know it's going to get better. You'll go into this cycle on the right where there's no fear involved. You confront it, you deal with it, you move on. But on the other hand, if you have a pain experience and now there's some what's called catastrophization, which is the inability to see anything than the worst possible outcome, then you get into this fear cycle where you start avoiding the activities you enjoyed, you start getting depressed, or you create a disability from it, and you just kind of go in this circle that goes round and round and round, and it just perpetuates upon itself, and you don't come out of it. So this is where we as physical therapists now are able to intervene and produce some pain neuroscience education to say, okay, this is what's really going on in your body. This is, you know, this is how things really are working. Educate you about what the pain experiences truly go like, and maybe we can get you out of this fear cycle and say, okay, there is some hope here, and you will get better, and or you can manage this a little bit better, and things start going in the other direction. So the next thing we come to is an area called yellow flags, and these are things that can speed up that cycle here, where you get in this loop, and it can just magnify things or fan the flame, as if you will. So failed treatments. So how many of you out there have been to Dr. ABC and XYZ trying to figure out what's wrong or get some answers? So you get frustrated with that, and that goes along with also different explanations. The more providers you see, the different explanations you're going to get, so you don't know who to believe, what to believe, what. So those can just magnify the symptoms that you're experiencing. Family issues that come up create more stress, which elevates or makes the nervous system more sensitive. Same with fear and anxiety. If you're having financial issues with insurance or whatever, job satisfaction, all these things can just perpetuate your pain experience. So yeah, there is a lot of yellow on this slide. So I know this sounds really bad and makes you kind of sad about our current state of affairs, and but we come to episode 4 and there's a new hope. So this is where physical therapy comes in, and hopefully we can start changing the environment that you guys are in and start providing some hope for you. Our goal as physical therapists, and hopefully as healthcare providers in general, is to be able to identify, okay, what's wrong with you? How long is this going to take? What can you, the patient, do about it? So what interventions can we provide to you to kind of make life better for you? What can the physical therapy or medical provider do? And then how much is it going to cost? So hopefully when you come into a provider, those are 5 questions that most patients will come in with, maybe not up front ask them, but usually those are things you want answered, and hopefully we can provide those answers for you during your care. And each one's individual and specific to you. And so for myself and many other physical therapists out there, this is what we should be doing. So we want to do a thorough history. So the who, what, when, where, and why of what's going on with you. Usually implement some outcome measures just to kind of get a baseline of where you're at from a function standpoint, kind of specific to what your problems are and what you would like to accomplish. Also be able to identify, is there, we use a pain catastrophization scale to say, okay, how much fear do you actually have in regards to this without maybe even recognizing it? And that leads us to a different type of treatment where we do a lot more education. Maybe we need to bring in a psychologist that deals with pain specifically and kind of build an alliance where we have multiple providers trying to provide your care. We will go through a functional screening process to see, okay, how well you move overall and what impairments specifically are affecting you most and how can we best treat them. We may go through some more specific movement, mobility, strength, sensation testing, really to try and narrow in what's the biggest problem here. And then really discuss with you what findings we come up with, educate you on those things, and try and figure out the why behind it. So we wanted, to the best of our ability, to give you a biological reason and not just give you a label to it. So, and that's been way overused throughout medicine, is just giving you a label but not telling you really what's going on with your body. And I think we need, as healthcare professionals, do a better job of explaining what's really going on with your body. So the pain neuroscience education portion is where we go through and explaining your pain through various stories and analogies to help you understand what's really going on and give you some framework. And I'll give you a couple examples that I've either been exposed to or have come up with on my own that I share with patients a lot. And then we go through what intervention is going to be best for you. My colleagues that I work with in our clinic, we've been able to identify 22 within our clinic different interventions that we can provide to patients. And some work well for some and some work better for others. And it's finding that right fit for each patient. We try to discuss the importance of exercise and movement. That's really important for people with fibromyalgia or chronic pain. We tread a little lighter with chronic fatigue with some of the new research that's coming out, and working really closely with your doctors and figuring out, okay, what's the best approach to managing this, especially from an exercise proportion. And then establishing goals, and goals that are specific to you and what you want to get out of your care and healing. There is a part of the examination that we have to be aware of and identify, and these are what we call red flags, and these are things that you need to see your physician immediately about. And these are just a few of them. So trauma, if you have pain at night and you're waking up for no reason at all, but you're in pain, you can't identify it. Unexplained weight loss, weakness that's unexplained, like you drop, you're dragging your foot for no reason. Saddle paresthesia, so that's numbness and tingling around the groin area. A possible fracture if you're losing bowel or bladder control, it's unexplained. If you have history of cancer, and then recent infection. Okay, so what is pain neuroscience education? And that's where we're going to spend the majority of our time in the rest of this talk. So Louis Gifford, he's out of the UK. He's since passed, but he identified that patients will go to therapy for low back pain, and you'll learn a ton about your low back, but there was a missing piece. You weren't learning about the pain, and that was the reason you were there in the first place. So, so we started trying to come up with interventions on teaching people about pain and their experience themselves through various stories and analogies, and how pain is processed in the brain and in the body. 2002, Lorimer Moseley that I mentioned earlier was able to find, did a study that said doing pain neuroscience education to see improvement was for every 2 people you treated with pain neuroscience education, 1 of them got better. And to just improve pain, every 3 people that you treated showed an improvement. At least, for every 3, 1 got better. Now you compare that to other things, other interventions in the literature, so like gabapentin or Neurontin, the number needed to treat is 6 to 1. So for every 6 people that you give Neurontin to, 1 of them's going to show some improvement. So, and there's no side effects with pain education compared to many of the drugs that are out there. So basically, the take-home message with this is the more knowledge you have, knowledge is power. So let's start educating you about your brain and nervous system and how pain actually works. So did you know that each one of you have 45 miles of nerves in your body? That's basically, if we stretched out all the nerves in your body, we could go from here in Salt Lake all the way down to Provo. So it's the most elaborate alarm system there is out there. So you have over 400 nerves in your body, and it is constantly working. And each neuron alone, carries 5,000 to 10,000 connections between each neuron. Now here's part of that I really like is, so your nervous system makes up 2 to 3% of your body mass, yet it takes 25% of your blood. And your brain takes 20% of that alone. So nerves have their own blood supply that go to it, and it's kind of like a viscous solution. It's almost like motor oil type thing. So the more you move, the more that nerve gets bathed in kind of fresh blood and stuff. But they've shown that the more sedentary you are in situations, the thicker that gets, and it's harder for fresh blood and information to get through to that. And then it gets magnified more if you have other conditions like diabetes and stuff like that, that it really tends to bog it down. So that's the importance of getting more movement, because nerves really, they do thrive on space, movement, and blood. So one thing I hope is a take-home message for you guys tonight is pain is a decision by the brain to its perception of threat. So think of it as pain is more of an output versus an input. So the nerves that come in to the brain, they're not pain receptors per se, but there are danger receptors. They're taking information to the brain. Brain takes that information and says, I don't like this. Let's create a pain experience, send it back down to stop you from doing what you're doing. So it's just kind of reframing how you look at things. And everybody's pain map is different. And I'll show you some slides here of some MRIs of people having pain experiences and what lights up. So it's not necessarily, what I want to say is patients that have more pain with movement is not due to the tissues getting worse per se. It's that your pain map in your brain and the nerves that go to it are just getting more efficient. It's like the more you practice something, the better you get at it. So the more kind of input that's coming up to the brain that's over and over and over, you just get more efficient at it. So it gets quicker, it gets faster. It's like, oh, I know what that is. And and you stop the activity before it even, really creates any tissue damage. So what we try to do is we try to teach you about your elaborate alarm system and how it's become so sensitive. This is very, very normal, but 1 in 4 people, that alarm system doesn't calm all the way back down. So we share stories about rancors, or if you're from South Africa, lions, or here in Utah, maybe rattlesnakes, and how your body responds and how it can relate to your pain experience. We talk about sliding glass doors, nosy neighbors, how to calm your nerves, memories of your grandma, CEOs, and emotional measuring cups. Those are just some of the stories that we will often share with patients and how it relates to your pain experience. I'm going to give you an example of a couple here. So we talk about sensitive nerves, and everybody has a resting kind of nerve activity, just to say that you're alive. And everybody has a pain threshold, that top dotted line coming across. So you can see on the left-hand screen, you have lots of room for activity there. That's normal. When you have a pain experience, like say, for instance, you bump your toe on the edge of a corner of a step or something, you experience a pain, you stop that activity, you limp around for a second, and then normal situation is that sensation goes away, the threat's gone, you kind of come back to normal. Well, in 1 in 4 people, that experience may not drop all the way back down, because your brain has decided, like, that's a threat. If I even come close to that again, I'm not going to allow myself to do that again. So it increases your nerve sensitivity level of taking information much higher. So in the future, now you only have a little bit of room to do activity compared to what you used to. So what we try to do is to take this sensitivity down through various interventions and education techniques, and we try and see if we can get that nervous system to kind of calm back down, back to normal. So here's a kind of an example that I came up with. So I have a 9-year-old son who loves Legos. Okay, and how many of you have ever stepped on a Lego? Okay, it hurts. And the typical response is not just slipping and falling or stubbing your toe, it's way up here, like, and it gets magnified if you've told your son 10 times to pick his Legos up off the floor, or you just had a 12-hour work day, or you have bills that are piling up, or you just got in a fight with your spouse, or, then that gets magnified even more. Well, that's basically just a sensation coming up from the bottom of your foot, shooting up to the brain. Brain says, ow, like, knock that off, step off of it, get away, and cause a pain response. Well, what if I was to lay a whole bucket of Legos on the ground and have you walk across them, but set this room on fire? I bet you the majority of you would be able to walk across all of those Legos and not feel a single one of them. So why? It's the same sensation coming up to the brain, but yet probably even more so, because now you have 1,000 Legos you're stepping on. So it's the same input coming on, but your brain has said, I have something bigger I need to worry about right now. It's that burning room. Then I'm going to ignore all the rest of this input coming in right now because I have bigger things to worry about. So it just kind of shows, like, it's not so much of an input coming in, it's not a pain input, it's more the output coming down from the brain that creates that pain sensation. So this kind of gives some proof to this. So we always thought this, but now we actually are able to image this and identify it. So this is called a functional MRI here on the screen. And it kind of goes over those 9 different areas that I was explaining there, and also shows the difference of pain experiences. So this was an image done by Adrian Lau and Louis Prudenera, and this was done in Las Vegas. And this was of a high-level dancer, to the best of my recollection, and she was experiencing back pain. So what they did was they took an MRI of her brain just at rest. And that's this top image here. So you can see everything's really quiet and stuff. Then they had her do a painful movement with her back. So they had her bend forward and try and touch her toes. These are all the areas of her brain that lit up with that pain experience that correlates with that. Then they took her back into a room and they did some pain education stuff with her and just kind of taught her about pain. And then they had her do the same movement again 15 minutes later. And that's what showed up on her brain, her brain scan again. So you can see it's really quieted it down. Part of that's, they were able to educate her in a way that she was able to reduce some of the fear of what she was experiencing. And so it didn't change her tissues at all, but it changed the perception of the brain going out. So how does it work? So what's the process of actually going through this pain neuroscience education? Physical therapists are primarily the ones that teach this, although other healthcare providers can, but what we found is physical therapists understand the anatomy and physiology really well and we typically have more time than other healthcare providers to provide this type of education. It works best in one-on-one sessions. Each session typically will last 15 to 30 minutes of kind of question answers and some stories. And it takes 6 to 10 sessions over the course of 4 to 6 weeks is on average. Now there's variations patient to patient. I've had some where they can only come in one time, and so we blast it out in 90 minutes, and it's intense, but it's what works for them. But we also do the best of our ability to introduce some exercise and some other physical therapy interventions to help with the PNE and help reinforce this. And what we found in research is that doing the education plus some kind of exercise intervention is superior than just doing the education alone. There's still benefits to both, but the one with other interventions tends to work a little better. Homework is given after each one because we want you involved in your healing process. We don't want it just to be a 15-30 minute and then you forget it. So we give you stuff to really think about and ponder. And it is covered by most health insurances. It just falls into your physical therapy benefits. And small group sessions can be done at times, similar to what we have going on here, but we can get into more specifics. They're not quite as effective because typically it has to be a little more generalized versus one-on-one where I can be specific to your problems and much more close dialogue, but it can be done. So, so that's one part. So the pain neuroscience education is one of the pillars in kind of managing pain management. There's 3 other pillars that have been kind of identified, and one is exercise, sleep hygiene, and goal setting in here. So, and like I said, we as a clinic, we identified 22 others that can be effective, and here's a list of what we've been able to come up with. Manual therapy is just hands-on treatment, doing some joint mobility, some stretching, soft tissue management. Functional dry needling is an area that I specialize in, and it may or may not be appropriate in your area that you're at, but here in Utah it's able to be done and quite effective for people that have suffer from chronic pain, fibromyalgia, and chronic fatigue. Pilates is another good one. We have a couple Pilates instructors in our clinic that have been having a lot of success in treating patients with chronic pain, and really understanding like how the body moves and understanding your pain to be able to get you to just move safely. Aquatic therapy has been shown to be really effective in these chronic complex pain because it takes a lot of the weight off of you. and you can move a little easier in the water. So, I mean, motion is lotion, as I was saying, we often say in the clinic. You know, just if we can get you moving a little bit in a comfortable, safe environment, life's good. So, and you can see a lot of these other ones, even just some basic modalities, like a TENS unit. Many of you have probably experienced before. There is value to it, especially in the chronic complex pain population, because you got to do something to kind of calm that nervous system down a little bit. Is it going to fix you? No, but will it calm you down a little bit to where maybe you don't need to take that pain pill quite so quickly or as often? You know, maybe that'll help. So, and you know, you can look through the rest of the interventions that we've come up with, but you know, and we're creative, and that's one thing that physical therapists are good at, is being creative and trying to identify what's going to work for you. And I've had some people that they just need to draw and draw out their pain, and then we talk about it, and you know, and figure out, okay, what does that mean, and how does that relate? So so this is geared more towards fibromyalgia and our chronic pain population, but the importance of aerobic and strengthening exercises and the principles in managing your pain. So what we'll often do is have you journal or keep a log of what activities you are doing. It helps us as your ally to figure out what's working well, what's not working well. And if you are accountable in writing it down, you're more likely to actually do it. We try to only prescribe 3 to 5 exercises at a time, because if we found if you do more than that, or we prescribe more than that, you won't do any of them. So, and you don't have to do exercise every single day. I think that's a big thing, is people get frustrated because they miss one day. Oh, I give up, I'm not going to do it anymore. We allow 2 outs a week, and you figure out what your out is. And you know, you just may have a bad day, but you know, knowing that you try to exercise 5 days a week is that's really valuable. And just a fun fact for you is, all you need to do is do a 10-minute brisk walk, and that's getting your heart rate at about 100 beats a minute. And if you can sustain that for 10 minutes, it's basically like you open up the brain's pharmacy of allowing its own endogenous chemicals and hormones to be released to promote its own hyperalgesia. So that runner's high that you may have heard of, that's what's happening in here. So people that run 6 miles, they get the endorphin rush that is equivalent to a shot of morphine. So, so we have the strongest pharmaceutical pain relieving chemicals in your own body that we can't produce outside of that. So if we can open those up, oftentimes you're going to feel better. So set a schedule for your exercise that's consistent in days and times. People with chronic pain or complex immune type conditions tend to do better with exercise earlier in the day, where your cortisol levels are kind of peaked, versus doing it at the end of the day when your cortisol levels drop and you tend to be more fatigued and worn out. That's not a good time to exercise. It's best to do it earlier in the day, is what we found. And it really comes down to avoiding that boom and bust type cycle that many people get into when you wake up and you're like, oh, I feel great today, I'm going to clean the whole house. And then you pay for it for 3 days. So it's really trying to educate you on how to pace yourself. And even though you're feeling good, maybe only clean one room at a time and then come back to it. You're more likely to be able to succeed throughout the week than going through these really highs and lows. And we use the term here, tease it, touch it, nudge it. And when you're trying to increase your exercise activity, you don't want to, oh, I worked out for, or I did exercise for 10 minutes today, I'm going to go for 30 minutes the next day, and I'm going to go to 2 hours the next. It's really just kind of easing your way into it and really taking inventory of your body and how you're responding to things. And this is critical in those patients with chronic fatigue syndrome that are capable of doing some light exercise. It is really critical to understand how your body's going to respond to that, and working closely with a physician and your physical therapist, and really kind of teasing and touching, nudging that very slowly. And you know, for some with the condition, it's really effective, and for others it may not be appropriate. And so that's where it's working with your medical provider and finding what's right for you. And then these are the mantras that we try to teach our patients down here at the bottom. So sore but safe. So it's okay to be sore, and you're going to be okay. Motion is lotion, like I mentioned earlier. And just because you hurt doesn't mean you're actually harming your body. So it's just that input that's coming in and just getting more efficient sometimes. You know, not always, but these are just some benefits of aerobic exercise that can be effective. So things like decreasing anxiety and depression, and improve that sensitivity of the nerve coming in. Obviously the cardiovascular health, and improving your diabetic insulin function, and decreasing your pain perception overall. So, two important things to manage your pain: educate yourself on how your body actually works, and to the best of your ability, move. So the comment will come up, well, wait, you don't understand. I have chronic pain or fibromyalgia. And, you know, many of you have had bad experiences in the past, especially when you've tried to exercise. And that's why, like I mentioned before, working with a PT or your healthcare team and understanding these conditions can help produce a safe and graded exposure type exercise program that hopefully will minimize these kind of boom-bust patterns like I was describing. Cognitive behavioral therapy, which psychologists will implement, and pain neuroscience education, which is very similar. It's just we, as physical therapists, will focus more on the cognitive part, so helping you understand, whereas in psychology they work more on the behavior portion of it. So they work really well together, but it's been shown to be more effective than just traditional psychotherapy. And like I said earlier, in regards to the chronic fatigue syndrome population, it may not be appropriate for you. And so that's where you need to really work closely with your healthcare provider and knowing, is this something I want to explore and experiment with, or am I not at that place at this time, or do we need to find other interventions that are best appropriate? So that third pillar here is sleep. People with chronic pain are aware that they don't sleep well. The National Sleep Foundation recommends that you get 7 to 9 hours, but people fudge on that on when they report how much they sleep. It's typically about 10% less at a minimum of what they actually report. So say you report you sleep 7 hours a night, it's more close to 6. And it's really important to have strategies to optimize your sleeping habits. And I have 11 different sleep recommendations that I give my patients, and just a couple examples of this is to set a schedule that's consistent, and that's 7 days a week. Turn off your technology 1 hour before you go to bed, so TV, phone, computer, and try not to take naps that are longer than 20 minutes during the day. And especially don't take naps after 2 o'clock in the afternoon, if at all possible, to really help improve your sleep habits at night. So those are just a few of the ones that I give out. The last pillar that we will go over is goal setting. So goal setting is just, it's so key in improving, seeing that improvement over time, because you need to set short-term goals and long-term goals. So we will give our patients short-term goals that are every 2 to 4 weeks, and then long-term goals that are hopefully, what's a goal that you have that in the next 3 to 12 months that you would like to achieve. Keep them SMART, so which is specific, measurable, attainable, realistic, and timely. And actually write down your goals. And this is one thing that I took for granted for years, because you say it, but when you actually have to write it down, there was a Harvard study that looked at exercise and trying to get people to start exercising. And what they did is they split them into 3 groups. And one of them was just get people to sign up. And they went through their initial intake and said, you start exercising. 38% of them, after I think it was 12 weeks, or actually kept up with the exercise. Then they took another group and said, okay, we're going to check in with you every week and kind of give you some motivation to keep exercising and stuff. Actually decreased. Only 35% of them did it. It's like that nagging person that keeps telling you to do stuff. But the last group, what they did was they did the intake, and then they actually had them write out what their goal was to be at the end of 12 weeks, and they made them post it in somewhere that was visible to them daily. 91% of them actually adhered to it. So actually writing down, and this goes across the board in all facets of life, but especially with exercise, it can be really effective. So coming here down to the end here, but this is really just building a lasting alliance with your healthcare team. And this can be physicians, physical therapists, psychologists, nutritionists, your Pilates instructor, massage, acupuncturist, anybody else out there, but most importantly, it's you. And it's all encompassing. You just don't want to go in and not be a passive participant in your healthcare and be dictated to. You really want to be involved, and it should be a collaboration amongst all these different providers. So, in conclusion, you're not alone in this. Your pain is 100% real. We proved that through MRIs, that your pain experience, you're legitimately feeling it. But it's not just in your head. You're actually taking that information in. Because they find something on an image, doesn't always correlate with your pain. So we call it wrinkles on the inside. You got wrinkles on the outside, they don't necessarily hurt. Got wrinkles on the inside, it's the same way. The more you learn and know, the less fear and threat there is. Nerves like space, movement, and blood. And then those 4 pillars that we talked about. So education, exercise, sleep, and goal setting are kind of the 4 pillars. And then practicing those sayings: sore but safe, hurt does not equal harm, tease it, touch it, nudge it. And there is hope, and that you're going to be okay as we go through this journey. So I got a good feeling about this. Okay, open this up for questions.
Have any questions?
If any.
So, one thing, some comment, we haven't really gotten too many questions here, but I think one comment is to stress that this is a general presentation, and that certain things apply more to fibromyalgia and chronic types of pain, and then there are some takeaways for those with chronic fatigue and ME/CFS.
Yeah.
So a lot of the exercise portion was really meant to be focused more on fibromyalgia and other types of pain. Am I right about that?
Yeah, you are correct about that. And kind of what I said is, really working with your healthcare team to, if you have chronic fatigue syndrome, to really determine, is any kind of exercise even appropriate? Because there may be some subsets in that chronic fatigue syndrome where it may be appropriate to try some real light exercise that's very well closely managed, but for others it probably is not. And so, but there's tons of research out there supporting the use of exercise for fibromyalgia and other chronic pain conditions that is critical in managing this. So, yes?
I have two questions. You mentioned the disc. Sometimes you think you have a ruptured disc,
Mm-hmm.
and that will tend to repair itself.
Mm-hmm. It can, yeah.
Many people that I've known, and myself included, have pain in the back, but it feels more like a muscle spasm that's
Correct.
pulling the spine askew.
Mm-hmm.
And once you can get rid of that muscle spasm, I don't know if there's any particular therapy that would help with that.
Mm-hmm.
And let me go back to my second question, which may be what I would like you to address. You talked about trigger point needling.
Yes.
Tell me about that.
So trigger point dry needling, it would be specifically for that.
Would you repeat the question? We're not mic'd over here, so when you get a question, if you'll repeat it, please.
I'm pretty loud.
Yeah.
Yeah,
Do you
you'll
want
need to repeat it.
Do you want to repeat? So the question was that for certain kinds of back pain where it feels almost more like a muscle spasm that's pulling on the spine and preventing movement, or that what kind of interventions would be appropriate for that, or what could help with that. And the second part of the question was, what is trigger point dry needling? And they your first question is answered by the second question, I guess you could say. So trigger point dry needling is been shown to be very effective in treating muscle type conditions or neuromuscular type
Is that like
conditions.
acupuncture?
It's different than acupuncture. What trigger point dry needling is, we take a monofilament needle, so we're not injecting anything. We insert it into the muscle and are trying to elicit a twitch response in that muscle. And in doing so is like hitting a reset button on that muscle. So it gets the muscle to get back to its resting tone. And if it's a really tight muscle, it gets it to somewhat relax. But if it's a muscle that's underperforming or not functioning the way that it should, we've seen it to where it actually kind of wakes it up and allows it to contract the way that it should. So it's a very safe and effective treatment that's available to patients sort of across the majority of the country.
I'm totally, for my personal self, against pain medication, opioids. About the worst it gets is ibuprofen or Aleve.
Uh-huh.
That when it's really, really painful, I
Mhm.
can use those, but not pain medication.
Mhm.
And that's what I'm thinking, that a pain medication would tend to exacerbate the whole thing,
It has that potential to.
because it just hides it. It doesn't really
Yeah.
affect it.
Yeah, it puts a mask on it, and with repeated use, it can actually increase the sensitivity of those nerve receptors, which can actually make your pain experience worse.
That's what I thought.
Yeah, over time. But things like the dry needling, this is where the pain neuroscience education kind of came out of, is like, okay, if we're going to take opioids and narcotics and pain medications away from people, what are we replacing it with? And so we need to come up with something to offer patients. And this was, this is one avenue, along with the dry needling is another great adjunct to implement to give some pain relief that we've found. Yeah.
So there is a question on Facebook.
Mhm.
I think, okay, yeah. So the question is that when you're talking about fear, so the question is, many of us do not truly fear pain. Is fear truly the right word or descriptor, or does it have a different connotation in this discussion?
So, yeah, I guess fear could have a different connotation of it. And so fear kind of multifaceted, because fear could be from a prior experience, like if you had an injury or a situation that you were in. Like, for instance, if you were in a car accident, there's a certain fear that's associated with that. The next time, like you're in a car, or next time you hurt your neck. But yet there's studies out there that show, like, people that are in demolition derbies and get in 20 car wrecks a night have no neck pain at all. So part of it's the situation that you find yourself in, that can elevate that pain cycle. The other part of it is fear of the unknown, of not knowing what's happening to you. And so not understanding, and that's where the education part comes in. So the more you know about what's going on with your body, it's innate, like the less fear you're going to have about the situation. So hopefully that answers.
Yeah, and so in a case of chronic pain, where you have pain, 24/7 basically.
Right.
How does fear play into that, or is it more just is it more to try and accept that, hey, I have this pain and that it's not?
I have this pain, and part of it might be the fear of movement. I mean, because you hurt, maybe you hurt all the time at rest. Well, if I hurt at rest, I'm going to hurt significantly more if I move. Maybe initially, for some people, but finding ways to move maybe in a safer, non-threatening way might be more effective. And so it's getting over that hump could be helpful.
Okay.
Yeah.
Could these techniques be helpful with someone who's been suffering from plantar fasciitis?
Definitely. Yeah. And I can speak to that right now because I have plantar fasciitis. Yeah, it can be very.
Support in your feet.
Yes, yeah, and there's kind of the list of 22 things that many of those would be very effective, but also just understanding how plantar fascia even comes about, and then what can be done, like what's the normal course of action, what else could be involved in it, what can you do, what other interventions are out there to help with that, and that's, I think a lot of this, and I'm practicing some of these right now, and some of I should practice a lot more. But yeah.
I had that, and I used orthotics, and it was totally amazing
Uh-huh.
how it helped relieve that pressure,
Yeah.
and it healed.
Yeah.
But you have to get good orthotics.
Right. Yeah.
I don't know, there may be other solutions.
Yeah. There's, stretching, some manual therapy, dry needling, just the education. Sometimes we have to do some splinting or some taping to help specific exercises that can help either stretch it or strengthen it in that area.
Are you comfortable in answering a question regarding severe headaches? Do you have recommendations for dealing with severe headaches?
Severe headaches, yeah. That's one thing I see a lot of. And it's a lot of those same concepts, those 4 pillars are key with the patients that I treat that suffer from headaches. And headaches is really not that different than pain in the rest of the body. It just manifests a little bit differently, and there's a bunch of different types of headaches, and so it really depends on what type of headache you're getting, and what are those triggers, and identifying them, and then how do we manage it. So is it coming from the neck? Is it coming from the jaw? Is it a migraine type situation? And so the education portion is really key. Getting some good medical management to understand what it is, and then a lot of those that I mentioned before, those interventions, we find is really helpful in managing headaches.
And even migraine headaches?
Migraine headaches too, because, and that's where working with a medical provider that understands migraines and how they work from a vascular standpoint, but also they're typically triggers, physical triggers, so like in the neck, like tension type headaches that may trigger a migraine. So trying to manage those, you know, the education about sleep and sleep strategies, stress management. It's really identifying what those triggers are for migraines and how best to manage those. Is really, but I treat a lot of patients that suffer from migraines and have had a lot of success. We don't get rid of them completely, but we can reduce the intensity of them or the frequency of how often they're occurring. But I have a couple doctors that I work pretty closely with that manage it from a medication side and trying to get the best kind of pharmaceutical management for it.
All righty, we'll wrap it up now. Thank you so much
Okay.
for your time and
Yeah.
all this great
Thank you.
information. Appreciate it.
Yeah, thanks.
All right, thank you.